طيب، بسم الله الرحمن الرحيم، وبه نستعين والصلاة والسلام على أشرف المرسلين. Our talk today is Miss Breast Cancer, Mammography, Pitfalls and Perals. Can you tell me the difference between these two images? Any volunteer to show me what is in the different in these two different images?
Assalamu alaikum.
عليكم السلام.
The image in the left side would be artifact from the motion artifact, and on the right side it is normal. No artifact in here.
Okay, but at the end, what do you think? Is it a micro classifications with artifact, or what is going on?
Yes, there is a classification, but the
Blur.
motion, the artifact blur the image.
Blur due to motion, but actually this is only artifact. It is not a true micro classification, while the image on the right is DCIS, but too much similar. David Getty division, a scientist at BBN Technologies of Cambridge, said that the most difficult radiographic exams to interpret is the standard mammography. A mass which is 3D lesions to be seen in two-dimensional image of the breast. Subtle lesions may be masked by underlying or overlying normal tissue and thus be missed, result in false negative detections. And normal tissue scattered at different depths can align to mimic a lesion, leading to false positive detections. Okay, as you know, mammography is the standard of reference for the early detection of breast cancer. The purpose of screening mammography is simply to detect a potential cancer. However, the radiologist should not try to make a diagnosis on the basis of screening finding alone. What is the difference between the two words I highlighted? Detect and diagnose. Detection and diagnosis. What is the difference between the two? Sarah.
Yes, Dr. Rabba.
Why I highlighted?
Okay. Usually in screening mammogram, this is our aim. There is abnormality or no abnormality. Is it negative screening or positive screening, or there is positive abnormality?
Okay.
So after that, if there is any abnormality, we will give by RAS 0. Then after that, to do diagnostic mammogram, we have to diagnose. Yes.
Yes. Yes. Detection. To detect, there is an abnormality, but not necessarily this abnormality to be cancer or not. Just to detect an abnormality. But diagnosis, to characterize the lesion to reach a diagnosis. Okay, to define the lesion, if it is cancer or if it is a benign lesions, by assessing the lesion by its characters. So if you notice that they are always saying mammography is a standard reference of early detection, not saying early diagnosis, early detection, early picking of cancer. Okay, so as you know, the 2D mammography having a lot of limitations and pitfalls. And the major limitation of which is the tissue superimpositions, okay? Along with high density and artifacts, along with the other pitfalls can mask the underlying lesion, result in false negative on cancer missing in up to 30%, and therefore decreasing the mammographic sensitivity. Same factors can have different effect, mimicking the cancer lesions and give a false positive, and therefore decreasing the specificity of the study or of the mammography. So what is a false negative? The false negative, it means that previous normal mammogram in any cancer found clinically or on mammography. يعني إيش؟ يعني results occur when mammograms appear normal even though breast cancer is present. The mammogram normal, but the patient having breast cancer. According to data from the breast cancer detection demonstration project, the false negative rate of mammography is approximately 80 to 10%. And after evaluating retrospective versus blinded interpretation of mammogram, others have concluded that the rate of missed breast cancer is as high as 35%. The importance of false negative is that the result can lead to delays in treatment and a false sense of security for the affected woman. Okay, definitely during your work, you have seen for yourself and for your colleague some missing of breast cancer or other missing error in the reporting of the imaging. See? But this is human. Every human work is incomplete and having a shortage. And there is an ancient talk since 1060-88 and 170-44 for Alexander Pope. He said, to err is human, to forgive divine. And another Franklin said, to err is human, to repent divine, to persist devilish. Also ancient talk, and the base talk is our prophets. More than 1,400, he said, كل ابن آدم خطاء وخير الخطائين التوابون. So we have to study hard, to work hard, okay, to overcome the limitations and to do well. And our objective for these lectures is to discuss various factors affect the detections of breast cancer on mammography, to review common factors leading to errors in assessment and management of breast lesions, and to improve awareness about the imaging characteristics of a variety of subtle malignancies, exemplifying some of the common pitfalls which are overlooked or misinterpreted that can result in delay on breast cancer diagnosis, and suggest some screening and diagnostic setting management strategies to avoid errors and delay in assessment of management, false negative findings. We are not going to talk about the false positive in this session. Okay. So what is the path of failure? It's either failure to detect a lesion at all, or failure to assess the lesion correctly, or failure to manage the lesion correctly. But at the end, these all lead to miss our opportunity to diagnose the breast cancers. In general, failure to detect or correctly characterize breast cancer can be attributed to four major factors: technical factors, patient factors, lesion or biological factors, and reader or observer factors. Starting by the technical factors that influence the ability to see the cancer is poor breast positioning, inadequate tissue compression, or improper age exposure factors, under or overexposure, blurred image due to motion or presence of artifact. And remember that the only adjustable factors post-acquisition is the contrast. And also age of the film sometimes can be contributing factors as technical issue. Patient factors mainly is limitations of breast compositions, and with dense breast, the sensitivity of mammography can be as low as 50 to 70%, and these definitely can be the high breast density inherently present, or sometimes the density can be acquired, like those who have received postmenopausal hormonal replacement therapy or reducing weight and increase the body index or so forth. And there is one entity also we found affecting the mammographic sensitivity, which is a complex texture, complex heterogeneous textures. Not necessarily the breast density to be very high, type C or type D, to reduce the sensitivity. Sometimes even ACR-B with coarse, complex texture can reduce the study sensitivity and hide small breast lesions. And it will be aggravated and can hide more or larger lesions when it's being associated with high breast density. Regarding reader or observer factors causing interpretations error, is either clean misinterpretations, incomplete evaluation, or inappropriate follow-up due to imprecise correlation with results of other studies, or lack of perceptions due to subtle lesions or distracting lesions when you have seen a large benign abnormality that very obvious, distracting you to visualize the subtle suspicious findings, and these can be influenced by suboptimal viewing conditions, outside distractions, lack of systematic approach, lesions seen on single view, lack of knowledge of clinical findings, and non-belief. While the lesion factors, these can be, the cancer can be look not like a typical cancer, which can be suspicious or unusual characteristic, and we can divide it into two major factors, either location factors or lesion locations. And if you remember, we talked before about the bar zones or review or forbidden zones, which require special attention and to review mammogram after you read the first reading. And these include retroareolar area, axillary tail, medial posterior breast along the inframammary fold, and retromammary fat. You remember the Milky Way and no man's land, and especially if associated with a single view abnormality. The other factors is the lesion characteristics. As you know, breast cancer is a heterogeneous disease and not always presenting in the same imaging appearance. It might have a different look and different appearance that can result in overlooking or misinterpretations. And under umbrella of these, there are many scenarios, including stable lesions. The lesion might be slow or not apparently growing. The lesion can be very small, that cannot be appreciated, slowly developing asymmetry, benign appearing nodular masses, or the lesion can be seen in a single view And as you know, invasive lobular carcinoma usually grows in different way other than the invasive ductal carcinoma and other breast cancers, which make it difficult clinically as well as radiologically. And breast cancer can engulf surrounding adipose tissue and giving apparent fat-containing lesion, which can result in misinterpretations. Diffuse infiltrating cancer can also be difficult to be appreciable. Architectural distortion usually subtle, difficult to be differentiating from the adjacent normal tissue, especially if it is of the same density. And the shrinkage breast might also result in apparent folds. You might think the contralateral larger breast to be the abnormal side, and the scar carcinoma usually is challenging. Multicentric, multifocal contralateral disease are also important scenarios, and sometimes intramammary lymph node, small lesions presumed to be an intramammary lymph nodes. This my patients long time before, you see, I checked for the imaging and I found that the CC view is inadequate, and there is expected to have much posterior breast tissue missing. I repeat it, and you can see the posterior cancer is present, and it was outside of field of view due to poor positioning. And to take home point is, as you know, detections of breast cancer is reliant on optimal breast positioning and the productions of good image quality. So your technologist should be strictly adhered to positioning standard and technical requirement to maximize the amount of breast tissue that image and decrease the false negative. This is also my patient. Can you imagine these two large breast cancers on MLO were not included in this CC view? So since we could not see the posteriorly the pectoralis or retromammary fat, we have to use the posterior nipple line for evaluating the CC view. And again, this is poor positioning technical factors, and advise you never accept incomplete or improper mammogram. Just to remind you, crucial component of well-performed mammographic examination are correct positioning, adequate compressions, proper image factor, and lack of artifacts. And this image also my patients here representing edge of the film abnormality. Good enough that most of the lesion could be appreciated in this image, but sometimes you might see only very small part of the lesion, and this is one of the common mammographic fault to miss breast cancer. And this lesion we had done for her ultrasound and demonstrate the typical shadowing invasive cancer. So this is edge of the film, and the important point is to know that the edge of the film refer to any finding visualized at the margins of the image, and even if seen in a single view, we have to consider it, we have to clarify it, we have to do other views, and at least to do ultrasound to make sure if there is a true lesions or only just an artifact or tissue, normal breast tissue seen at the edge of the film. It's very important also just to remind you to adhere to proper technique so as not to miss the cancer. So we had 3 examples just demonstrating the inadequate radiographic techniques. Let us see other factors. Can you appreciate any abnormality in this image? Yes, it is really subtle. Yeah. But with this spot magnifications, definitely you could appreciate the segmental pleomorphic calcification in a case of DCIS. See? This overlooked subtle suspicious abnormality, but remember to use spot magnifications, compression views to evaluate for the subtle calcification. Would you see any abnormality in this mammogram? Any appreciable findings?
Asymmetry in the right breast.
Where?
In the right breast, global.
Yeah. Global? Okay, good. You picked the abnormality in the right breast. Okay, this is a CC view.
Okay.
Now?
It is. Okay. Yes, there is added density or asymmetry, but also there is architectural distortion involving the posterior aspect.
Yes, there is a mass. Now here there is a mass. There is a circumscribed partial obscured mass. Okay.
And the outer.
Or indistinct. And it looks like something like that. And I agree with you, there is some subtle distortion. So there is indeterminate findings. What is next?
Compression.
Compression or
ultrasound.
Or ultrasound. Yes. This our patients, the lesion obscured by an inherent dense parenchyma. This is a huge or large mass in the right breast. And if you look here, the lesion, it looks like more or less well-defined. However, we cannot describe it as well-defined because of micro-lobulated borders. We cannot say this is a circumscribed. Okay? It has a micro-lobulations. And just to remind you that some of the cancer might be seen as circumscribed on mammography, but if you have done spot magnification or ultrasound, you will find the lesion actually indistinct or micro-lobulated. And we have to emphasize the use of adjunct ultrasound to further evaluate indeterminate findings seen on conventional or on mammographic findings, I mean. Okay. This is also our patients, and you can correlate the mammogram with ultrasound. Could you appreciate the findings seen on MRI, on mammography, the corresponding findings? This lady having a fungating left breast cancer. So the mammogram could not be done for the left breast. However, is being performed for this is the right breast, see, and no, the left breast and the right breast we could do for her a mammography, but it demonstrates just small, see, small group of calcification here and single dot of calcifications. Otherwise, we could see nothing. And the findings of this clump segmental calcification seen on the lateral aspect, where there is nothing, could be appreciated on mammogram. See, in a patient demonstrating even ductal DCIS with microinvasions on the contralateral sides. So missed due to limitation of inherent breast compositions. And you know that the conflict effect of the inherent breast density, you see, that compromise the ability to detect the mass or any abnormality, especially the mass if non-calcified or non-distorted. And the lesions having similar density to fibroglandular parenchyma or have no or little effect on the normal tissue, definitely it will be occult on mammography. And as we mentioned before, the mammographic sensitivity can be as low as 70 or even 50% on a dense mammogram. But we have to use the other imaging tools, especially ultrasound, and in problem cases, we can use breast MRI to further evaluate the dense breast. And you know that MRI is more sensitive than mammography in detection of non-calcified DCIS and its invasive component. Okay, this lady is 30-year-old having a palpable abnormality, okay, underwent a diagnostic mammography. Could you pick an abnormality in her breast?
In the central part of the breast,
Mhm.
there it looks like a mass or asymmetry or focal asymmetry in this.
There is asymmetry seen only on the CC view, could not be
Okay.
appreciated in the other. So
Asymmetry.
single view asymmetry we had done for her ultrasound and demonstrate indistinct heterogeneous mass, which was invasive cancer, invasive ductal cancer. So this is single view as well as inherent breast density, high breast density. See, that is a lesion here. Yes. So egg does not exclude malignancy. The patient 30-year-old, and in dense breast, we have to pay special attention for any densest area. Look for any area more denser than the rest of the breast. Take it in your account and work up asymmetry, especially if palpable. Any asymmetry corresponding to palpable abnormality, you have to take it with considerations. And in cases of palpable masses, and it's better to use the BP on mammography. It will help to appreciate any corresponding abnormality. And also you can use spot compressions and ultrasound, and you have to make use of the clinical breast examinations. Okay. In a case of single view finding, the red flag features that should elevate the suspicions are corresponding palpable abnormality, associated microcalcifications, associated distortions, interval development of gross findings, and is there tissue at the same depth on the orthogonal view that could obscure the lesion. And if you have seen a lesion and you could not see it in the other view, but you expect at the same locations, there was a tissue that might obscure the lesion. Also, you have to consider these lesions and do further workup. Okay, this is 41-year-old female patient, medically free with history of breast lump for 1 year. Could you expect at which side the palpable abnormality? She has a palpable abnormality or lump for 1 year. Huh? This is good bilateral CC view, good image quality. Could you appreciate any abnormality in this image? Would you expect which side is a palpable abnormality?
There is focal asymmetry at the left breast, left median, central.
Okay. Any other suggestion?
Left outer.
Okay. Any other suggestion? First of all, what is the ACR of this breast? The density, the breast
C.
density.
C.
ACR2.
Okay, this is C, excellent. But C toward D or C toward B?
Toward D.
Huh?
Toward
D.
D.
Is it extremely dense?
No.
Or
In some areas. Mhm.
no, but it is toward D. Yes, it is
Yes,
heterogeneously
towards
dense,
B. Towards B.
but toward D. Yeah,
Yeah.
there is a
Yeah.
lot of fat,
Yes.
it's toward B.
Yes.
But look for the texture. Look for the textures of the breast tissue. This is what I told you about. This is a complex. This is a complex texture that make it difficult to evaluate breast tissue in spite of not very high density.
Abundant fat.
Even you might see it with less breast density, with more intervening fat, okay? But due to complexity, okay, heterogeneity and complexity of the underlying breast parenchyma, the appreciation of the underlying lesions will be difficult. This patient having abnormality in the right breast. Can you appreciate it on the MLO now? Still is difficult. Still difficult. Yeah, still it is difficult. Why it is difficult? Because the breast parenchyma, even look for the MLO. For this parenchyma, you can see more fat than the parenchyma, than the fibroglandular breast density. But this parenchyma is very complex, make it difficult to appreciate any underlying lesions. There is, and the lesion effect on the underlying normal parenchyma is subtle, giving minimal effect. If you look here, there is subtle distortion on the fat glandular interface. So any patient with extreme or heterogeneously dense, and here we should add complex parenchymal texture. See, we can add the complex parenchymal textures, not necessarily to be extremely dense or heterogeneously dense, but even less denser breast, but having complex parenchymal textures. You see, we have to consider it and we have to proceed. You see, especially if the patient having palpable abnormality, definitely we expect she might have an occult lesions, probably an occult cancer. So we have to do,
Compression.
or
Ultrasound.
Ultrasound. MRI.
nowadays before
Tomography. Tomography.
yes, tomosynthesis. Yeah,
That's
we should use
tomosynthesis.
adjunctive imaging tools like tomosynthesis and our ultrasound, and probably later we can proceed for MRI. Look for these lesions, typical malignant, non-parallel, irregular with angular margins and echogenic rim. You see, microlobulations. Lesion very typical with very lesions vascularity, corresponding to the palpable abnormality. We will go and see it on the mammography. If you look here, again, is very subtle distortion to be seen here. Look for the tomosynthesis. See? Look for the tomosynthesis. Look how it appreciates and speculated mass at the same locations. Evaluating the 2D like what? Like looking at the cover of a book. But when using tomosynthesis, as if we open the book and looking inside, which for any page. because it will improve visualization of distortion, delineate underlying masses with better margin characterizations. And it is especially useful in evaluation of possible distortion along fat glandular interface and at the apex of breast, because here the summation of breast tissue is more common. See these areas, there is more summation of normal breast tissue. That is why tomosynthesis is helpful. It is not my case, but I have taken from our system in the department, you see? This lesion. What is your opinion about this case? Fatty breast, very obvious. So what about the interpretations? The detection is very clear. R1 resident can detect the abnormality in this type of mammography. But what about the characterizations? How we could characterize these lesions? To classify it as BIRAD? Quickly, BIRAD?
BIRAD 4C for me.
Excellent, BIRAD 4C. Why BIRAD 4C?
Okay, because
one word, I need one word. Tell me why BIRAD 4C, because of?
Speculations.
If it is speculated, it will be 5. But we are not sure if there is speculation or not. But we are sure these are
irregular shape.
Indistinct. More the positive. Usually we said we have to classify the lesion by the more suspicious or more malignant features. Which one is more having more positive predictive value? The irregular shape or the indistinct? The indistinct.
Indistinct.
Yeah.
Yes.
So because if I will say these are indistinct, then it will be BIRAD 4B. But because are high density and irregular, it will be BIRAD 4C. Because I add another features. Okay, so I can proceed to characterize it further. Are suspicious.
Yes, ultrasound.
Okay, this is a tomosynthesis now. Give good characterization, you see, and demonstrate the speculation you suggested on mammography. Now it become BIRAD 5. And this lady reported by the radiologist having BIRAD 5 multicentric disease.
Yeah.
You see, but unfortunately, the pathology and even the ultrasound was corresponding to mammography. Look for the largest lesions, typical malignant, and this is also suspicious lesions. Okay, the smaller one is also in the presence of this is most likely it will be the same. But unfortunately, the pathology of the smallest one was invasive cancer, while the biggest one, the pathology was sclerosing adenosis. And here I brought this case, okay, just to have or to show the importance of MDT, especially for the cases of pathology radiology discordance. But unfortunately, at that time, the patient not discussed on the MDT, okay, and managed according to the pathology result, wide local excisions of the smallest lesions, and they left the largest one. And the patient came later with progressions of the retained malignancy in her breast, and then later discussed in MDT meeting and ended by total mastectomy. Okay. Huh? Can you see any abnormality in this mammography? Would you appreciate anything here? You can say normal if it is normal. Is it if I'll tell you this is screening mammography, you will report it as positive or negative? This is really interesting case. I like this case. We learn a lot from this case, but try to be a little bit quickly. You can say positive or negative. Who said it is positive? Raise your hand.
For me, it is positive for further evaluation, yes.
Who said
Positive.
positive? Who said positive?
Sarah?
Also, I think it is positive.
Which side? Which side? Which side?
Left side.
Right side. Yes.
Who
Left.
said left? Who said right? Hindi said right. Where in the right side?
There are multiple يعني in the medial part there are multiple don't know, these are masses or multiple.
Okay.
In the
Okay.
left also there is something central يعني just at the level of the areola at the center يعني
Here.
أيوة and towards the posterior also and here and
Here.
yes. وفي right in the medial part يعني I can see
Here.
small areas. Yes, I did.
Okay. Sarah, you said the left one.
Yes, in the CCV, in the MLO, I see in the posteriorly, in the lower part of the breast, posteriorly in no man's area. There is focal asymmetry.
Excellent. Well done. Excellent, Sarah. MashaAllah, good observer. Okay.
Yes.
Can you see any abnormality on the ultrasound? Okay. I start by this. You see, actually, this patient not started by mammography or ultrasound. This patient, she's 36-year-old having, 36-year-old having bleeding, vaginal bleeding. See, they have done for her CT chest, CT cap, CT chest and abdomen, looking for the cause of vaginal bleeding. And this is the CT abdomen.
Multiple bony lesions, multiple lytic bony lesions.
Excellent, well done. Excellent, well done. Yes, her problem is bones, and this is Lyra. Orad, I mean Orad 1.
Yes.
You see, Orad 1. But this image demonstrates, you see, look, even she has collapsed vertebra. And well appreciable the bony lesion. She has extensive metastatic disease. And if you look for her age, she's 36-year-old. And her gynae, she has bleeding. She has her uterus is unremarkable apart from the endometrial fluid. It has nothing. So what is the cause of this bone metastasis? The bone scan was negative. It's brought to discuss in the MDT meeting. This is a test lungs and mediastinum were, and this is the bone. Okay, how we can make use of this CT chest? The lungs and mediastinum are okay. Do you want to see anything else?
You can check for the breast in this in CT.
Excellent. Excellent, well done. We can look for the breast. Could you see any abnormality here?
طيب.
Huh?
طيب. The
Axillary lymph
left
nodes.
axillary lymph node positive. Okay. I don't know, but maybe in the first image in the right side, in the right side of the screen.
Huh?
Okay, in the first row, I think there is a left breast mass.
Excellent, well done. Yes. Yes, there is a lesion here. You see this lesion, and this is part of which and surrounding subtle distortion corresponding to that area seen on mammography. When they show this image, you see, we raise the suspicions that this lady most likely having the primary side is left breast cancer with axillary lymph nodes. Okay? And we recommend for her mammography, ultrasound, and MRI because we expect her breast, it was very dense. You see, even here is dense. We recommend for her the dedicated breast imaging, okay, and biopsy. Definitely, these lymph nodes, you see, are pathological, but not only pathological, and are suspicious. See later. And if you look here, the lesion, can you see it in the axial view? The lesion is just anterior to the lower part of the chest wall. And if you look here, this is the lesions on the sagittal view, and look for the axillary lymph node, are heterogeneously enhancing. And even the surrounding, there is surrounding nodal edema and some enhancement, which is unusual with just reactive adenopathy. Okay? Because of the collapsed vertebra, they recommend for her MRI, which demonstrate typical appearance of metastatic disease along with some cord compression due to the collapsed vertebra and typhus formations. So they decide to do for her biopsy, okay? And they had done for her left axillary biopsy of the left axillary lymph node, as well as blindly from the exact locations of the left breast asymmetry. And the result was negative for cancer for that regions, and on the axillary, because they said there was no abnormality, just taking blindly from that regions. And from the lymph node, the result was reactive adenopathy. So they had done the mammography and rediscussed the patients, and the mammography was reported, ultrasound and mammography at that time reported as normal. Because really it is subtle findings. And if you look for the lymph node, having abundant fat, but still it was metastatic, look for the asymmetric cortical thickening. See? So they discuss it, and we raise for them the probability of this to be the site of lesion corresponding to CT findings, and it was not convincing for them, but they decide to do bone biopsy. Okay, if you look here, This is the area of interest. They decide to do bone biopsy, and at this time, the bone result was metastatic adenocarcinoma. So they were looking for the site of primary, and then they decided to do for her breast MRI. We could appreciate the same lesions seen on CT. Is 1 centimeter lesion here. You see that is the one. This is here on post-contrast, and it was seen also in pre-contrast image, and this is a subtracted image as the site, the suspicious findings, and the axillary lymph node are highly suspicious. If you look here, even as if the capsule is not intact, there is enhancement, there is some spicules, and there is enhancement in the pre-lesion edema. It is not a simple edema, and even some of the vessels, okay, afferent vessels entering the capsules from different other than the hilar region. There is a suspicions, and also, because there is some asymmetry in the contralateral, you look here, it was not too much convincing, but they decide, okay, to repeat corresponding to the metastatic adenocarcinoma of the bone, and these findings, they decided to repeat the axillary lymph node and take more tissue. And this time, fortunately, we have a Sudanese pathologist, a competent one. He diagnosed breast cancer with molecular phenotypes of estrogen progesterone receptor positive HER2 negative from the axillary adenopathy. And then after that, and also 3 or 4 times for radiologists, they tried to do searching for the breast lesions on ultrasound, but they could not appreciate. Okay? And based on this result, they sent the patient for PET scan. And if you look here, this is the bone lesions, and axillary lymph node, it was metastatic. And if you look here, the same locations, and the report of the PET is the left breast is the primary site, who is metastatic axillary lymph node, and the patient received treatment. And this is for 2 years, and up to date, I understand that the patient is okay, and she have a good response for our breast cancer treatment. If we go back, okay, this is the same location in the right breast. But if you look for the location in the left breast here, the same, this is not a normal parenchyma. It has a convex border, has a mask-like appearance, and inhomogeneous. It is inhomogeneous. There is central low echogenicity with shadowing. Definitely, this area is the site of the lesion. I'm not the one who have done this image, just I picked the image from the system, but from my experience, I suspect it's being missed because of hyper-echogenicity. The lesion is hyper-echogenic, like the parenchyma. That is why it's being missed. But retrospectively, if we look for a hyper-echogenic lesions, to say a benign lesions or part or parenchymal island, it has to be homogeneously hyperechoic. We should not see, okay, heterogeneity or hypoechogenicity within it, or being, okay, giving any shadowing. If it is like that, it will not be just a benign lesions. So collectively, if we look here, the lesions on CT, you see, in the sagittal, coronal, and here axial. very small, and here in the bed, here on MRI, and here on ultrasound, and here on mammography, and this is look, yani having abundant fat does not exclude the lymph node to be metastatic. This is a metastatic lymph node with still having abundant fatty hilum because the metastatic deposits was in the cortex, not still growing, okay, to obscure or to infiltrate the fatty hilum. So here, this is a very tiny lesion presenting with extensive bone metastasis, but fortunately, she has no metastasis in the lung or liver or other or ovaries. Okay, so the home message, I will leave it for you in this case. Any suggestion for home message or home point? Tell me what you learn from what you have learned from this case.
Always don't ignore even small breast lesions.
Yes.
We
Be
have
patient.
to.
We have to be patient.
Yeah.
We have, yes, because she's a female. Even if she's young, I was arguing on that way. Since she's a female, we have to think about breast cancer. We have to exclude breast cancer. And we have to consider any lesions to make sure it's not a cancer in this lady, since she has a metastatic disease, unless we could find other primary. Since there is no other primary, you see, breast, it will be number one.
Yes, focus.
We have to, consider the breast. حتى يثبت براءته. بالنص كنت بقول حتى يثبت براءته. That is why we approach the case in that way. Unfortunately, she's okay now with this, but even look for the breast cancer sometimes how it's aggressive. 1 centimeter, very tiny lesions giving extensive metastatic disease.
Yes.
Okay, so we discussed some of patient-related factors. Let us go for other factors. Okay, sorry. Came already. Okay, this lady, she's a Sudani lady, my neighbor, she has breast pain. She has left breast pain. We had done for her the mammography and revealed very subtle architectural distortion in her inferior half of the left breast without any associated mass, but very, very subtle punctate calcifications, very subtle. So we proceed for ultrasound, and also apart from just mild distortion, we could not appreciate any masses. Then we proceed for MRI, and if you look for the MRI, look for the, this is T2, demonstrate distortion and hyper intensity edematous breast extending from the prepectoral down to the nipple with even ducts, you see here associated with ducts in a segmental and adjacent skin thickening even here, and the skin thickening is enhanced, and look corresponding clump segmental enhancement. Findings are suspicious, and it was extensive BCIS with microinvasions. See, we raise also suspicions for contralateral breast based on the MRI, on ultrasound, and the mammography was occult. And at that moment, just nothing on the conventional image to be biopsied for this one, but based on mammography, based on MRI, retrospective, they try to take a biopsy. Unfortunately, the result was malignancy and end with mastectomy. And after 3 years, the disease in the contralateral breast had been progressed, and the contralateral mastectomy also performed. So take-home points is identifications of architectural distortion is very important because it has high positive predictive value for breast cancer. It's up to 60% of cases. Difficult to perceive because it is subtle findings. Sometimes might have similar density to surrounding parenchyma. If you look here, it is almost the same as surrounding parenchymal density. So that is why, and most of the time frequently seen in one view of standard mammography and associated with area of fats. That is why make it difficult to be appreciated. MRI is problem solving for unclear finding on conventional imaging. We have to remember, we have to use it to help ourselves to confirm the presence of abnormality and further characterize it. So this is a site of the DCIS on mammography. Okay. This is a 32-year-old lady with left breast pain.
There is a mass at the, with the speculation at the posterior part of the breast with the subtle invasion to the adjacent pectoralis muscle.
You cannot decide on this. You can say projected over the pectoralis, suspicious for, yes, this is a zoom view. This is zoom. I have missed the standard. I have missed the standard. It was, these subtle speculations was not very clear on the standard view. It looks like an oval lesions, and because she's a young lady, you see, you might think about a fibroadenoma or something like that. But this is a zoom view, demonstrate the subtle speculation, which become more evident on the spot compression magnification view. You see the indistinct and speculated margins, and even on the compression view, the lesion is still high density and it was invasive cancer. So we have to consider the additional view, especially spot compression for the subtle changes. Well, any abnormality in this lady or normal mammography, if it is screening mammography, positive or negative?
Positive at the left breast.
What is abnormality in the left breast?
There is an area of focal asymmetry at the center of the left breast.
Which clock?
I think it is 6 o'clock. 6 o'clock.
6. It is lower.
2.
12.
12 o'clock. It is at 12 o'clock. There is focal asymmetry.
Yes.
Okay. Okay. This lady, she's old lady, elderly lady, having open heart surgery, after which she developed ulcer in her left breast after the surgery.
The skin at the lateral part of the left breast is thickened, focal thickening of the skin.
Yes, there is focal thickening expected to be, and the ulcer, it was about 3 o'clock. So this expected locations of the ulcer. So what is next?
Yeah, to do ultrasound.
Ultrasound. This lady, they had done for her 2 or 3 times mammography and ultrasound, and reported as negative. And they sent the patients, apart from the ulcers, and sent the patients for the dermatologist. Okay, and then they refer the patient for a dermatologist in our hospital, and the dermatologist, fortunately, they decide to start by doing breast imaging in the same institutions, okay, and then to exclude any pathology in the breast, and then to treat the patients. The patient came, I had done for her this mammography, and usually we have technologists doing breast ultrasound. She told me the study is negative, nothing is there. Okay, and this is her ultrasound. Would you appreciate anything? This is the 3 o'clock. You see the site of ulcer. This is the ulcer, and the dermal. Only it is very superficial ulcer. Okay, that is why they refer the patient for dermatology. There is no infiltrating mass of the underlying dermal layer. But she has still a mass. She has speculated heterogeneous mass. See, and these spicules, okay, giving some reactions, desmoplastic reactions, and making tethering to overlying skins. And this usually compromises the blood and result in skin ulcerations. Very little vascularity. This usually occurs with squamous type of breast cancer. This patient has squamous carcinoma, and she has a lesions also, suspicious multifocal lesions at 12 o'clock, corresponding to the site of asymmetry. Because it's also more or less iso to the adjacent fat, but having a thick echogenic rim. The echogenic rim misinterpreted as a normal parenchyma. You see, look here. So the patient having multicentric squamous type of breast carcinoma. These unusual presentations of breast cancer, subtle morphology. And as you know, mammographic visualization varies among breast cancer. Not all breast cancer presenting in the same way as speculated high density mass. And as you know, it is a heterogeneous disease, and not might appear and might not appear as dense, as very high density on mammography to be appreciated. Even if you go back, you could not appreciate the underlying mass beyond that site of the ulcer. So it is low density. Low density, if you see here, there is subtle speculation, subtle distortion here. So always we have to be patient. We have to carefully examine the patient, and we have to compare any abnormal mammographic abnormality with ultrasound. It's very essential looking for the subtle features and go and target the same area on ultrasound and compare it with the corresponding subtle abnormality seen on mammography. Okay? Compare with this ulcerating mass, look how it is dense, and then infiltrating the underlying epidermis and then the dermal layer. Look how it is invading the underlying dermal and then the epidermis. these two examples of breast cancer when both are presenting with ulcers. However, the first one without infiltrating the mass, the effect of the mass giving ulcerations, while the other one is high density loculated mass infiltrating underlying skin. What about this example? 50-year-old lady.
There is an focal asymmetry, retroareolar,
Mhm.
retroareolar area
Mhm.
with associated skin thickening.
Is it
No.
asymmetry or mass?
Oh, mass. I think it's mass,
It
but
looks
I have
like circumscribed partial obscure, yeah? The deep
Yes.
portion within the parenchyma is not visualized, while the outer
retro-
part,
yes.
it seems to be well defined
well
within the fat.
circumscribed.
Uh-huh.
Yes.
Mhm.
The no associated microcalcification in this view.
Yes, no microcalcification, yeah.
There is also an small mass anterior to this large mass. I think it is extend to retroareolar skin.
There is band density from the mass extending to the nippel-areolar complex. So it can
Yes.
be ducts, it can
Duct
be
extension.
tuber bands, it can be anything. So what is your differential diagnosis for these lesions?
Partially obscured mass, I give it BIRAT 4B.
Okay. Uh-huh.
So we have to do
Why you give BIRAT 4B? Excellent, well done.
because
Though partial obscure, usually we are giving BIRAT 3.
yes, but
But why you have given the BIRAT 4B?
it is obscured with the associated ductal extension towards the nipple.
Excellent. Yes, these associations. What else? And it seemed to be, yes, it seemed to be thickened as you mentioned before. It seemed to be some thickening is there.
Retroareolar complex.
Yes, yeah, there is some, it looks to be thickened, and this band-like density and the patient age. We have usually to consider the patient age. Okay.
Yes.
The history, did you have seen the history?
Yes, she has right breast lump. I think it was talked about.
So it is palpable. It is a palpable abnormality.
Yes.
Even if it is circumscribed, this 50-year-old with palpable abnormality, we have to consider it at least BIRAT 4A and proceed for ultrasound.
Yes, we have
Set
to ultrasound.
for palpable, we are not consider it as 3. We have to work it up, to upgrade or downgrade the lesions. So we have to proceed for ultrasound. This is ultrasound.
Yes, ultrasound show.
Could you imagine? Could you imagine now?
Yes, this is
the difference between the two. It doesn't look ugly on mammography as seen on ultrasound. So ultrasound helping us to further characterize these lesions, to upgrade it to BIRAT.
This is 4C.
5.
Or 5.
BIRAT
Yes.
5. This is speculated mass with ductal extension.
Yes, we have ductal extension. Yes.
Yeah, ductal here, there is duct here, and this duct. Sometimes these ducts can be DCIS, sometimes can be the tumor extending through the ducts. But at least we can say ductal extension, regardless if it is invasive or DCIS. Okay, but this upgraded by ultrasound to 3.
BIRAT 5.
So BIRAT 5, I mean. So this is suspicious but subtle on mammography. Not very appreciable as take home, might be passed as papilloma. Okay. It can be papilloma, yeah, or يعني benign abnormality. So we have to emphasize the use of ultrasound, which characterize the palpable abnormality or mammographically detected mass. So to decrease the false negative rate. These patients, you see, 47-year-old having breast pain, left side, and I think she has some nipple discharge from her left breast. And this is also the zoom image. I have missed the standard view. I might find it one day. I show it for you. On the standard view, the findings are so subtle. With this zoom view, you can see some calcifications, okay, and subtle distortion. We had done a compression magnification view, which revealed coarse heterogeneous and polymorphic calcification in segmental distributions. Then, because we had done for her ultrasound that revealed segmental ductasia, some of the ducts are hypoechoic and others are echo-free. With the micro calcification could be ductal micro calcification could also be appreciated on ultrasound. The findings also suspicious or DCIS because of hypoechogenicity and presence of calcifications. See, then because of nipple discharge, we had done for her galactography. This is since long time, before 2010, these patients. And the ductogram revealed dilatations of the major and the minor ducts. The segmental ramifications, ductal system, all are mildly dilated, but not only dilated, demonstrate irregularity, irregular filling defects, and short strictures alternating with circulations, giving a beaded appearance. Finding are more suspicious or highly suspicious. Then we proceed for MRI, which demonstrates segmental clump enhancement corresponding to that ductal abnormality seen on galactography. And we raise the possibility of ductal carcinoma, extensive ductal carcinoma in situ. And if you look carefully on the zoomed image, you can see even not only clump, but you can appreciate cluster of ring, non-mass-like enhancement. And the patient was extensive high-grade, non-invasive component, ended with mastectomy. So, home point, use alternative imaging modalities such as ultrasound and nuclear MRI and nuclear to detect and diagnose breast cancer to decrease missing. Okay. This 25-year-old lady presented with a palpable abnormality in the left breast.
Mediolateral and craniocaudal, mediolateral oblique and craniocaudal view of the left breast showing oval shape, circumscribed, high density mass at the retroaerial region. No associated calcification, microcalcification. But as a craniocaudal, I see the upper part of the mass is have some speculation, or it could be obscuration by adjacent parenchyma. So we so we have to look the adjacent retroaerial area. I think it is have mild thickening of retroaerial area. So you have to do.
There is no thickening. There is no thickening.
You have to do a compression, a spot compression view of this mass for more characterization of the border. of the
Excellent,
margin.
well done. Excellent, excellent. In spite she's 25, but we have to characterize the margins.
Yes.
At this level, I can say 0 because I'm not sure about the margins.
Yes.
See, I'm not sure about the margins. If in the CC view, you might pass it, but in the MLO view, some indistinct margins, especially the margins abutting the area of the fat anteriorly. The lesion extends beyond the fat glandular interface. The contour of fat glandular interface extend beyond which, so and abutting the adjacent subcutaneous fat. And in spite of that, I could not see the margin very sharply. So I need to clarify it, either to do spot magnification or to proceed for ultrasound.
Yes.
This is
This is spot magnification view
Mhm.
showing the mass have indistinct border.
indistinct
With,
border.
Yes.
Yes, it is indistinct border. The only thing, the margins are indistinct, as we suspected on MLO, and this is MLO exactly. So it will
And,
be
this is a BIRAT 4B.
for
you
B.
have
So we have to
do ultrasound for
do ultrasound. Okay, this is the ultrasound.
the ultrasound showing that the mass is taller than wider, deeply hypoechoic, with
Yeah, now
adjacent-
they are using parallel non-parallel.
Sorry,
أيوة.
non-parallel orientation,
Same, but non-parallel lesions, okay?
non-parallel orientation with some specules more sharp at this at ultrasound, more than obvious
Yes,
mammogram.
there is speculations, and apart from speculations, we have
With
more
adjacent-
important
Yes,
the edge, the surrounding.
With adjacent
The
thick,
margin here, we can say the margin as
microlobulated and
speculated,
also there is
microlobulated, and
thick capsule.
excellent, indistinct because of this thick rind, not capsule. This is rim or rind. Thick rim or rind. See, which is suspicious, different from capsule. When we talk about capsule, we are talking about benign features. But when we talk about rim or rind, echogenic
This
rim,
is high suspicious.
This is high suspicious findings. Yes, non-parallel heterogeneously deeply hypoechoic speculated, and it was invasive cancer. And fortunately, it was, if you look here, it's projecting from the fat glandular interface into the anterior parenchyma. And she was lucky that to be picked as small as possible, you see, because it placed anteriorly. Okay, because anterior placement. And on mammography, it has a benign appearing at the first glance at least. That is why easy to be missed, and egg does not exclude malignancy. She is 25-year-old, and we have to remember that circumscribed lesion still can be cancer, okay, in 1.4%, and usually those lesions, when we have done spot magnification view or ultrasound, it will appear not to be really circumscribed, as in this case, and we have to proceed and work it up to avoid missing cancer. 50-year-old lady screening mammography. Medina, are you there?
Hi. Yes, I'm here.
This for you.
This is CC and MLO views of the right breast. screening mammography showing ACRC.
Mhm.
Okay.
It is a screening. So is it positive or negative?
It is positive. There is diffuse mild anterior skin thickening.
The left breast demonstrates same this skin thickening. Same thickness.
Same thickness.
Yeah.
Okay. So I see in the CC view there is a densest area.
You call it as,
in the retro.
how you label this area?
I think it is a focal asymmetry because in the MLO it is not seen.
So if it is not seen, it will be focal, or it will be, the focal asymmetry is, it should be seen on MLO as well as on CC view. But if it is seen in a single view, it will be, we call it as
asymmetry, just
asymmetry. We call it as asymmetry only. So you have asymmetry, excellent to pick it up. There is asymmetry. But as you know, on screening, not all findings, especially for single view findings, you see asymmetry on a single view will be just pass it as, but be superimposed tissue. Especially that this thickening, this skin thickening is seen both sides. Suspect to be periductal mastitis or something.
So I need to a compression view in order to.
Nothing was done for this lady, and she came in the second round. This is her second round. Look for the skin thickening. This is after 1 year. This is the mammography after 1 year.
Okay, the CC view shows a well circumscribed mass lesion in the retroareolar medial part of the right breast.
Would you appreciate it in the MLO?
I think yes.
We said the mass, if you could see it on a single view, you will call it as asymmetry until it proves all criteria to be visualized in the two views. If you could not appreciate, you will still call it as asymmetry, even if it looks like a mass.
Yes. Okay.
Since you have seen the other view.
Asymmetry. Still asymmetry. Because in the MLO I could not appreciate it well as in the CC view.
Okay.
But
and for 1 year and for 1 year interval, yani the skin thickening is more or less the same.
The same, yeah.
So that is why. Again to be missed. Was breast cancer being missed into screening mammography, overlooked because single view, and slowly developing asymmetry. We have said before, one of the reasons is slowly developing asymmetry, okay, or stable cancer with little or apparent no growth. So here it become more appreciable. So this I consider it as developing asymmetry because it become more appreciable. But the associated features, the skin changes, is stable.
Yes.
So it will be
honest.
deceiving, but it was the patient was breast cancer. So single view finding is a dilemma usually in a screening mammography, because most of which is not real findings, but 83% of screen detected single view findings are due to superimposition of normal structures on either routine or callback images. However, breast cancer tumor growth pattern can vary, and tumor may not necessarily grow concentrically, so you can see it in a single view of the standard view. Still, single view abnormality can be cancer, and most of the single view abnormality are normal tissue. That is why it is a dilemma, especially for screening. If the patient is diagnostic, it will be more easy. But for screening screening setting, it will be a dilemma and it will be a problem. Retrospective studies of cancer visible on prior mammogram but missed, most of these were previously seen in a single view findings or seen as a single view findings. This is one issue. Also, I think tomosynthesis can help us to delineate this abnormality and characterize it. And we have to know that a lesion with suspicious morphology but is stable for 1 or 2 years still require biopsy. It may represent slowly changing cancer. Okay, what is the doubling time of breast cancer? What is the doubling?
3 months.
Okay, suggestion. Other suggestion? Doubling time of breast cancer.
Depends on the type of
We start
carcinoma.
from 45 days.
So you have range from
45 days.
excellent. This is the lower
yes.
range, 45 days, yes. So an upper range, this is the lower limit. It is from 45, excellent, from 44 or 45 days up to
5 years. Maybe.
Excellent, well done. Abir?
Yes.
Excellent, well done, Abir. Yes, you are right. It is from 44 to 869 days, which is corresponding to 5 years. Up to 5 years, you might find cancer slowly growing.
Yeah.
Okay. You can read it. 40-year-old lady presented with 2 months palpable abnormality. Okay.
This is a view of this lady. This is a view of this lady showed her breast parenchyma to be in ACR category A.
Excellent.
It showed multiple masses. The largest one is well circumscribed in the posterior part of the breast.
the most posterior part
Posterior part of the medial or lateral or central?
of the lateral.
Posterior part of the lateral. Excellent. Well done, Abir. Huh?
There is a rather smaller mass anterior to it, with a little bit indistinct margins. The posterior margin of it is indistinct, and there is associated architectural distortion in this area.
So
I will give her. I need to see the MLO view first.
Excellent. Well done. You need to see the MLO. Yes, this is MLO. What is this dot? What is this?
Could be the label, the marker for the site of.
Excellent. This is a BB marker. Yes, this is a BB marker. Excellent. Well done. Okay.
So the MLO confirm the presence of the two masses, high density masses. The largest one has a well-defined circumscribed, partially obscured border. No associated skin thickening or calcification. I will give her Birat 4B.
Why you give her 4B? You said circumscribed, partially obscured.
The age of the patient, and she has a palpable abnormality as well.
So
it will architectural distortion.
Okay, excellent. You said there is distortion, and you said the anterior mass is indistinct and high density. Yes. Okay.
So I will proceed for ultrasound.
This is ultrasound.
The ultrasound showed complex mass with microlobulated borders and surrounded with a thick hyperechoic area.
Excellent.
I think there is ductal extension.
Excellent. Well done.
Yeah.
There is ductal extension. Yes. Yes.
So I will upgrade the Birat for this mass for 5.
Okay. So if you will go back, back, how you are going to describe? Look for the margins here.
This is the site of ductal extension of the mass.
This is indistinct, and some distortion is here. And this, even there is some spicules in these lesions. And this anteriorly, you can see speculations, indistinction and speculations. You see? And this is band-like going toward, this is ductal extension, interrupted ductal extension going toward this satellite lesions. This is Birat 5, and it was invasive ductal carcinoma. You see? So it is important to be wary of new mass that appear to be circumscribed at first glance. Okay, it is new. If you remember the history, it is 44, and this is only for 2 months. But you have to consider the history. And to remember again, circumscribed lesions still does not exclude, preclude malignancy. You have to characterize it further and to make sure of the margins. And as you know, ultrasound is very helpful in predicting the likelihood of malignancy, characterizing the lesions, and we have to correlate the ultrasound findings with mammography. What about this axillary lymph node? What is your impression about this axillary lymph node? Sarah Almak? أنا معانا مش كده؟
أهلا يا رباب، الحمد لله على سلامتك.
الله يسلمك. You are welcome.
There is multiple maxillary lymph nodes which are appear as large and slightly dense. The central hilum is not clearly seen. It's considered as suspicious lymph node.
Why it is suspicious?
Because it's a little bit dense and cortex
more or less
bulk.
the same as contralateral. And this is one lymph node. This is one lymph node lying over the other lymph node. This lymph node projecting over this one. Make it difficult
to appreciate it.
Yeah, difficult to be evaluated. And if you look here, the outlines,
the cortex
is oval and smooth. And because this projecting over this, we could not appreciate the fatty hilum. So it's really difficult to tell if these lesions or these lymph nodes are equivocal here. But if you go for
ultrasound,
look for ultrasound.
Yes. Yeah. Ultrasound shows
the fatty hilum is there,
but it is big and irregular, and there is bulky at the one side of the lymph node.
You have heterogeneous focal cortical asymmetry.
Yeah, yes, and heterogeneous. It's not
excellent.
at the same density.
Excellent. So
yes,
ultrasound definitely solves the problem. On mammography, we cannot see all these findings. You see, the hilum is present here, but the hilum is asymmetric, engulfed or attenuated due to the focal cortical thickening. But this will not be well appreciated on mammography. So ultrasound is superior to mammography, and furthermore is the gold standard and the best modality to evaluate axillary lymph node differentiating benign from malignant. And these benign appearing lymph nodes on mammography but are suspicious on ultrasound, so can be missed based on mammography. And if we look for these, we can say these are suspicious lymph nodes, are dense, lacking hilum. But in this case, it was benign due to benign cause. Pathological lymph node, but are not malignant lymph node. So mammography is not very helpful in differentiating benign from malignant. Yani, at least sometimes just we can say pathological lymph node based on mammography, and even pathological lymph node sometimes could not be detected based on mammography. Ultrasound is much superior. And the differential diagnosis in this include reactive hyperplasia, metastasis, Hodgkin lymphoma, connective tissue disorder, sarcoidosis, tuberculosis, and so forth. Yani overlapping between benign and malignant. Okay. Take this case.
I will take this case. Okay, for the mammography, it is CCU for the left breast. So there is a large area of, I can say, architectural distortion associated with thick skin, trabeculation, thickening trabeculation.
Excellent. Well done.
There is vascular calcification, no evidence of suspicious calcification.
Excellent.
Or yes, if I proceed to the ultrasound, it's shown here. Shown this, there is mass with vertical oriented, with second rim, with speculation, hypodense, posterior enhancement. So this is going with
only this
mass.
Adjacent parenchyma is also abnormal.
Yes, distorted.
Distorted and hypocoid. Okay.
Yes.
Okay.
Mammograph.
Confirm the skin thickening and eliminate parenchyma. Okay. So
yes, in MRI without contrast and post contrast, show on the left side, show there is an excessive hyper intense mass, you can say, with
hyperintense. Where hyperintense? This is contrast and this is post contrast.
These
are post contrast.
Yes, iso-intense in pre-contrast.
Pre-contrast does not show masses. It doesn't show masses. The pre-contrast demonstrates only diffuse edema. Okay, the breast is enlarging with thickening of the parenchyma as well as the skin.
And post-contrast show there is multiple areas of contrast enhancement areas.
So we call it as we call it
masses.
Okay, if we call a mass, then we have to see it in pre-contrast. See, the mass is usually seen in pre-contrast. When we haven't seen and it is three-dimensional and have a convex borders and all these features, if not fulfill the criteria of space occupying lesions, then it will be
architectural distortion.
No, on MRI. If it is not, we have three types of lesion, enhancement lesion. The one lesion is
mass.
If it is not mass, it will be. If not mass, it will be
non-mass.
Non-mass enhancement, or yes, you have mass, non-mass like enhancement, and tiny 5 millimeter or less. We call it focus. On MRI, either we have a focus, we have a mass, we have non-mass like enhancement. If it is not focus like this one, if we have only this one, we can say we have a focus or foci. But these are larger than a focus. These are larger than a focus.
Mass-like.
Yes, so we have mass-like enhancement. And the mass-like enhancement we have, is extensive through parenchyma, multifocal, clump-like, non-mass-like enhancement. And what else?
And there is a skin thickening and also mass-like seen on the other breast.
No, this is the same. This is the same breast. These two views.
Okay.
This is the same breast. You see, different level. If you look for the skin, and
Yes, there is.
Yeah, this is subtraction image. This is both contrast and this is subtraction
This
image.
is subtraction. Okay.
Yeah.
And,
But
and
if-
there is area of enhancement within the skin itself.
Excellent, well done. Excellent. This is more important. So,
Yeah.
so the findings are suspicious of, and also the lesion seen extending toward the nipple,
The
which
nipple,
is thickened and enhanced. Okay.
And that is invasive.
Yeah, the skin, so the skin is thickened and enhanced.
Yeah.
And nipple thickened. So this case, and I have multiple areas of enhancement, small areas of enhancement. Okay, and corresponding lesions on ultrasound. So
this consider invasive
suspicious of
invasive ductal carcinoma. Or
it is invasive. It is invasive. Yeah, invasive cancer. It's okay. It is invasive cancer. ممكن تكون invasive ductal, ممكن تكون invasive lobular.
Yes.
But it is invasive cancer. It's okay. Okay. But suspicious for which type? Special type. When the skin is involved and enhanced, so indicate that this skin is being involved. And if you look here, if you see here even, and you see here, there is some structure, tubular structure, vascular structure going into the skin, enhancing with adjacent more enhancement. These are suspicious for inflammatory breast carcinoma. Lymphatic is spread into the skin, and inflammatory, and the case was inflammatory carcinoma. So on mammography, we cannot decide if it is for systemic cause, especially if the patient old baby. We cannot decide the edema is due to cancer or due to systemic cause, okay? Or lymphatic obstruction in the axilla or whatever. A lot of differential because the only presentation is edema without detectable masses or suspicious calcification. We have to emphasize on the use of alternative imaging tools, okay, to detect and diagnose breast cancer, and to remember that MRI tool of choice in evaluating patients with potential inflammatory breast carcinoma. Why? It can depict the primary breast cancer in up to 98% compared to only 65% on mammography, okay? Because usually inflammatory cancer presenting as small infiltrative nodules, not a large mass-like or extensive calcifications. The presentations, that's why not very easy to be picked on mammography. Okay, what about this? Abir?
For the previous case, I have a question. Actually, I didn't get what you mean. Is it a mass-like or non-mass-like enhancement for this case?
Non-mass-like enhancement.
Okay.
We said we have focus, we have a non-mass-like enhancement, and we have a mass. Okay. If it is not a focus, look for is it a mass? And you know the mass is a space occupying lesion, 3-dimensional. If it is not fulfill the criteria, then it will be non-mass-like enhancement. Okay. And this is non-mass-like enhancement. It is multifocal clump enhancement. Yani the distribution is multifocal. Okay.
Okay.
And the internal structure is clump enhancement. So he's going with suspicious abnormality. يلا take this عبير.
Okay. This is a CT view of a left breast. ACR category C. Showing there is asymmetrical skin thickening. With skin edema and coarse trabeculation.
Excellent, well done.
There is a segmental area of asymmetry. Extending from the retroareolar area backward.
Excellent.
Okay. I want to see the MLO view for more characterization of this asymmetry.
Okay, there is asymmetry, excellent. There is edema asymmetry. What about this area?
My first impression was inadequate compression. I thought that this overlapping of the skin.
No, not overlapping. If it is not overlapping, it will be?
So it will be an architecture distortion. Like a tethering of the breast parenchyma or the fibroglandular tissue at that site.
Okay, any question you would like to ask?
Any previous intervention for this patient?
Yes, there is in previous intervention.
What it was, biopsy or surgery?
No, surgery, wide local excision.
So I need the previous images just to make sure that these changes are due to the surgery.
Oh, therapy, excellent, excellent, well done, excellent, well done. Architecture distortion and edema diagnosis, you need to see the previous, okay. So, you have it, So,
okay.
Quickly, Abir, what about you?
Okay, the previous image showed speculated mass.
Just in comparison to the previous, is it new changes or the same changes as before or whatever?
No, it's not a new changes. It looked like that it's it's just from the intervention.
Okay, look for the skin.
There is there is a denser area in the previous image, which is not shown here, replaced by fatty tissue. Just retroareolar.
So these changes, is it new, progressive, or the same as before?
It's not progressive for me at this mammogram.
Are you sure? Okay, can you see the skin here? Can you see the skin here?
Yes, it's more thickened and more edematous.
And look for the fat here. What do you see? Look for the fat in between. There is distortion, there is architectural distortion, but even look for the distortion here at the nipple area and retraction. Is it the same? Here, at least you could see the nipple. Here, there is more retraction. And look for the thickening, skin thickening and the trabecular thickening here. It was there. Could you see it? Could you appreciate it here?
It's more here in the recent image.
So
but,
what does it
I couldn't.
signify? What is the significance of that?
So it's either disease progression or consequences of the intervention. If it is acute, I mean, if the image taken shortly after the surgery.
No, this is post-surgical, Abir. You have done this case before, and in an excellent way. I don't know why now you are confused. That is why I
thought
said
the first image is
for you,
pre-surgery.
please take it, Abir, because you have taken the same case in a discussion of architectural distortion previously, and you pick it up that the previous, okay, the same patients, same image. Previously demonstrate the architectural distortion due to post-operative only, okay, without anything, and on interval the patient developed breast edema with more distortion and increased density, trabeculation, and skin thickening. So it will be suspicious for
disease progression.
It will be progression, yes, it will be suspicious for
recurrence.
For recurrence. This is recurrent cancer.
Yes.
You see? This is recurrent. This is scar carcinoma. Yes, scar carcinoma is difficult to be diagnosed. And usually we have to compare with, always you need to correlate with a baseline or previous image is very essential to diagnose or to pick up the scar carcinoma. And it will be more difficult if cancer developed at the site of scar due to the previous benign pathology. Because for the cancer pathology, you expect recurrence and you are going to look for that. But if the previous pathology or prior scar, or the scar is due to prior benign pathology, you might miss the cancer because you have already distortion due to previous surgery. And just we have to look if there is any fullness, or if you have calcification moving, the calcification move aside or become more fragmented than previously. If you have dystrophic calcification getting fragmented or moving in its place, or the scar showing some fullness, then you have to consider that you have a mass arising at that area. Okay. So we went through the lesion factors, and let us see the observer factors. What about this mammogram? This is my second missing, okay, missing cancer case in my experience. Is the second one. Early on, not now, not current, before 2010. I had missed this case.
Can I take it?
Definitely, yes.
Yes. I think the problem or the lesion on the left breast, there is a dense mass with area of speculation more posteriorly and indistinct margin. No area of calcification. However, there is small area of skin thickening. And also there is another focal asymmetry on the upper outer region for the left breast. About the right breast, also there is a mass, but it's look like more. One of them is well circumscribed. Other one also indistinct margin with
It's only one.
area
It is only one.
on the right one.
Yeah, it is one.
You mean?
Yeah, it is one lesion.
Yeah. The clear one, it is rounded, rounded, and can say it's
high density or equal density or low density. It's rounded, rounded, circumscribed.
Rounded, circumscribed with I think the same density of the breast.
Equal density,
Yeah, yeah. And there is also posterior in the right breast. There is posterior focal asymmetry.
Where?
On the left breast, posteriorly.
Left or right?
Yeah. I mean right. Right. There is an
Here?
obliteration.
This
Obliteration.
one?
Yes. Yes. Obliteration of the posterior fat.
This is projection, same as here. Projection.
Okay.
So your birat.
I will take the big one, birat 5 according to the left breast.
Yeah, birat 5. Yes. And the right it will be.
The right could be a birat 3. Birat 3.
Okay.
So I would like to do a compression view for the both lesions to characterize the margin of the lesions.
Okay.
More characterization of the lesion. If not, I will proceed directly for ultrasound.
Ultrasound demonstrate this is the spot for the right one.
Yeah. 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 I can say there is small area of indistinct margin, more anteriorly. And the density now is heterogeneous density. It's not the same. It's not the same density.
So ultrasound revealed lobulated echo-free cyst.
Okay. Okay. So I'll consider on the left breast.
You will report it
as birat 2.
Unfortunately, I had done the same mistake. That was my mistake. You see, because it was echo-free. Okay, echo-free.
Yeah.
But and only the wall, are lobulated only. Okay, and I ignored the surrounding distortion. There is subtle distortion. My experience at that time is not much. You see, I have missed the surrounding distortion, and I have missed this pathological lymph node. Even the lymph node here is not as pathological as that node. That was metastatic lymph node, and that the patient has bilateral breast cancer.
No, but because you told me that's a cyst, ultrasound.
It was a cyst, yeah. You will see it. I'm going to show it for you.
Yes, I think it is cyst with a ring.
No,
well-defined wall and echo.
It was a cyst. It was a cyst. But even if I told you the cyst, you have to tell me, there is some architectural distortion in the area. We have to look for the reason for this distortion, and we have to look for this pathological axillary lymphadenopathy, suspicious lymph node. You see, that is why I missed, really, I have missed these findings. Okay, and this is a zoom, even this is not a spot magnification. And with this zoom, you can see the indistinct margin. It was good to pick
there is area.
but indistinct margin with a cyst, it can be just an inflammatory cyst. And even this small distortion can be just an inflammatory cyst. I was thinking in that way and I ignored, or I did not characterize this axillary lymph nodes. And it was bilateral cancer. This is a cyst.
Yeah.
Can you see the cyst?
Yes.
There is some, the cyst is not irregular. Though it is echo-free, but it's not an irregular. Look for the posterior, this posterior region here. When we go back,
invasion.
look here, look here, look here for that tail. Look for this tail. You see?
Yes.
Yeah.
This could be
this one. Yeah, really, I mischaracterize. I mischaracterize. I pick the abnormality, I pick it up, but I mischaracterize it. You see, I misinterpret it. Because it was echo-free, I couldn't recognize this lobulation. At that moment, I did not, I was not concentrating on that area. Retrospective, I have looked at it, you see? And even if you look at it seemed to be hypoechoic rather than echo-free, this portion.
Yes.
Might be this is a cancer and adjacent to a cyst or presenting as a cyst. So the lesion had been mischaracterized as potentially benign because of individual features, circumscribed margins. Describe, okay, despite the presence of other suspicious features, which was architectural distortions. And so in a patient with newly diagnosed breast cancer, we have to re-examine the patient image and scrutinize the image for the ipsilateral or contralateral malignancies. Okay? And this is perception and misinterpretations error, both. Perceptions of these subtle findings and misinterpretations. And this is the same patient. Look here, this is the early, okay, early case. And this is post-neoadjuvant chemotherapy. The cyst, you see, significantly regressing, as well as the left breast cancer. I appreciate, okay, the left one, and I characterize it correctly, but I have missed the right one. And look for the lymph node, how it regressed post chemotherapy treatment. Okay.
Need to disappear. Yes.
Yeah, this is the here. You see, even there is some asymmetries, multiple asymmetries, and the adjacent to the cyst is being regressed on the follow-up. But I suspect this asymmetry, like in the contralateral, there are also a lot of asymmetry not proven to be suspicious for multifocal. That is why I suspect it is the same background fibrocystic Chinese. Okay, if you look for here, this is
what has raised your suspicion previously before that this was a malignant finding? The regression of the cyst size and the lymph node?
No. The pathology, the surgeon, okay, palpate the lymph node, and they came to me discussing the issue of the right lesions. After that, and I could recognize that lymph node, it's suspicious. See, they had taken a biopsy and proven to be malignant. And then the patient received the chemo. Then we could appreciate in retrospect that the cyst is not typical benign, not typical, not fulfill the criteria of the simple cyst. Yes, it has posterior enhancement and it is completely echo-free, but it is irregular. It should be circumscribed. This is not a circumscribed. So one criteria is missing, is not a simple cyst. And we described before, we mentioned before, the single most important descriptors is the margin for a lesion, is number one. Do you agree? Okay.
Yes, Dr. Thank you
Okay.
for sharing with us your valued experience.
Okay. So this is also my patients having bilateral malignancy. After that, يعني صحصحت. And then I start to pay attention for the contralateral breast, scrutinizing for any suspicious abnormality. And these patients having cancer in the left breast here as well as in the right breast. And this is also having cancer here and cancer here. So always we have to consider and carefully evaluate for suspicious feature in patient having breast cancer in the same or contralateral breast. Okay. Any volunteer for this interesting case? يلا quickly يا شباب نخلص بدري. ولا اتكلم انا؟ It's okay. This also our patients missed breast cancer. What do you expect? The cancer in which side? And why it's being missed? This 45-year-old having right bulbable abnormality.
Retroareolar mass.
You see, she has bilateral, multiple, some calcified, some non-calcified lesions. So expected, okay, to be bilateral, multiple fibroadenomas. But we could not appreciate this, or the radiologist who report the case not appreciates this skin thickening and subtle distortion seen here adjacent to this fibroadenoma. You see? And lack of perceptions. Why there is lack of perception here? Because of distractions due to an obvious benign abnormality. And this is her follow-up. And even the technique, the mammographic image here, it was not much better than this. And here, obviously, the distortions and even, you see, the circumscribed fibroadenoma, the wall adjacent to the cancer is being infiltrating by the malignancy. And in a case of concordant, collocated invasive cancer and a fibroadenoma. Interesting case. Can you see it here? Can you see it here? See, circumscribed, while the borders here is being involved by the adjacent speculated mass. On the spot magnification is very clear, but in the previous image, they did not proceed for ultrasound or for spot magnification view. And so in this case, breast cancer, because of distraction by obvious benign lesions, overlooked subtle suspicious findings. And it is common mammographic. This is common mammographic defaults to have to be distracted by a benign abnormality, very obvious benign abnormality. So this necessitates careful evaluation of these lesions. If you have bilateral multiple lesions, you have to trace it all and evaluate it all. And in woman over 40-year-old, concomitant occurrence of invasive cancer with fibroadenoma has been reported in up to 5% of cases. We have to consider it, okay? Okay. Huh? Bye, Rat. will be typical popcorn calcifications. Supposed to be BIRAT 2. But if you look for the underlying mass, it's projecting beyond the fat glandular contour of the fat glandular interface, and it is not sharply demarcated. There is subtle distortion and indistinct. So there is subtle disruption. This is my case. Fortunately, I did not miss it. I could appreciate this, but it can be easy missed because this is very typical popcorn calcification. You might say this is irregular hyalinized fibroadenoma. When I had done the ultrasound, very irregular, see, indistinct lesion. The posterior enhancement here, we could not consider it because of the calcifications. And it's a non-parallel mass, and it was a carcinoma. It was invasive cancer. Compare with this typical hyalinized fibroadenoma, you see?
Well defined.
Yeah, it's a circumscribed, it was associated with, so we have to be cautious when we evaluate hyalinized fibroadenoma, okay? And if you have seen typical benign feature, don't rush for final diagnosis before you make sure there is no any suspicious features. And we have to use complementary ultrasound for further characterizations, okay? What about this lesion, this mass, or this?
ممكن عفوا دكتور ربا، ممكن الصورة اللي قبلها شوية ثاني مرة ثانية بس معلش يعني. أيوة. أوكي بس كنت عاوزة أشوفه كويس خلاص.
الله يبارك فيك. طيب, what about this patient? Any abnormality here?
There is an area of architectural distortion associated with, I think, focal asymmetry or mass with a lucent area at the upper part of the right breast.
Excellent. Well done, Suhair. Well done. So now
on the medulla, on the craniocaudal,
yes,
it seems to be mass with a speculation or speculated
excellent.
mass.
Yes,
give
excellent.
it by
Well
5 or
yeah. So
for biopsy, give it by RAT5 for biopsy, and ultrasound for more characterization or association or in association abnormality.
For more characterization?
No.
Or
searching for another
yes,
any abnormality.
Yeah, looking for others. Even here, you can see band-like density going toward
extension towards the nipple.
Toward the nipple. And here there is fullness, the density, there is more density compared to the contralateral side, and the skin is relatively slightly thicker compared to the contralateral side, and we could appreciate part of lymph node. We could not further characterize it, okay? And this is the spot magnification. You can see the lesion here with long, very long spicules. Look for the spicule going so to the back of the image, okay? These are long spicule, and look for this is thick spicule going toward the nipple, might represent the ductal extension. This is the ultrasound. Demonstrate.
Ultrasound demonstrate irregular,
confirm the suspicious lesions.
With ductal extension.
Yes, with excellent, with ductal, with multi-directional ductal extension. So these long spicules, not only thin spicules, some of which is ductal extensions, irregular ductal extension. Look for this. This is a mass here, and look for this, how this infiltrating ducts going that way. This is also, and even if you look here, if we look for the first glance for the mass here, from one direction, we can say this is the only lesion surrounding with thick rim of halo, of echogenic halo, and heterogeneous hypopoid. But when we angulate, we can see more extension, and more ducts going. We have to measure all of these, and we have to consider it not only here, see, and throughout these ducts, there are multiple satellite. All these are satellite nodules on the way. So all these ductal extension with satellite nodules down to the nipple area. Here, these are ducts are suspicious just behind the nipple. So this is a multifocal disease. The whole quadrant is being involved. You see, the medial, upper medial aspect is being involved by multifocal disease. And this is very essential. And the missing is not only on mammography. This lady, before to be presenting with breast abnormality, had done for her CT chest for other reason, and the mass was there, but not being reported. See, look for the lesion, the first row here. This is the earlier few months before the presentations, and the lesion, if you look for the lesions, it was obviously seen, enhancing speculated mass here. This is the mass. I think 4 or 5 months difference between the two studies. And look for the nipple. Here, look for the nipple area. And this is the mass on the axial. Now the mass definitely is getting larger. This is the clip due to the biopsy, post-biopsy clip, and see that the lesions is larger than the previous. And look here for the nipple area. You see, the nipple area, retroareolar, becomes so busy. Look here, become much more busy than previously. And there are now satellite nodules. You see, these are satellite nodules you have seen on mammography. It was not well appreciated in previous CT. So it was also being missed, had been missed on the previous mammography. So if the message here, if you have seen an elephant, look for similar smaller elephant. Okay. If you have seen an elephant on mammography or any imaging, look for, okay, smaller one in its vicinity. This is like an index mass and the satellite nodules, okay? And this lady also missed breast cancer. Why? Because at the beginning, that was screening. Okay, this was screening mammography and could report it as single area of asymmetry. They could not appreciate this subtle correlate or corresponding area projecting over the pectoralis on the MLO. Okay, and usually single view, faint, equal asymmetry, usually being ignored on screening mammography. There was no other associated features. But the age of the patient is approaching 60. We have to consider this type of, and if we concentrate, we might see some ductal obesity here, far away behind the nipple, but can be just a ductal easy. See? But on the patient later, few months, presenting with left breast mass. The lesion is progressing, getting large. And if you look here, this is the lesions. This is a lesion now, getting large, becoming a mass, typical mass. High density, indistinct mass, okay? And look for it at ultrasound, is typical malignant one. And look for the duct extensions. The lesion here, first time missed on the screening mammography. This is interval cancer, detecting few months later after she presents with palpable abnormality. And this also small ductal extension is also being missed, reported as unifocal lesions with this measurement without this area of ductal extensions. Okay, and this is her CT chest, also a second missing. Okay, if you look here, this is the lesions, and these are ductal extensions. Look for the ductal extensions in the two directions, and look for the satellite lesions here along that ductal extensions, approximating the chest wall. And here the arrow, this is intercostal enhancing nodule within the muscle, indicate or signify involvement, signify muscle involvement. Okay, and if you go down, you can see posteriorly here, look for the two sides. Look for the skin on the left side, definitely thickened compared to the right one. And if you go, that is a lesion posteriorly. You see, this is a lesion, and this is part of which, and look for the ducts going from the lesion to the nipple area. And here you can see the mass and the involvement of the chest wall. Now you can see this is a satellite lesion, and the ducts going from the satellite lesion into the intercostal. Compare this intercostal with this intercostal to visualize the enhancing nodule. So she had another, the third missing is intercostal involvement. But we have to be cautious when, especially if the lesion is abutting part of, if close to the nipple, search for nipple involvement. If close to the pectoralis, search for pectoralis involvement. If close to the chest wall, yeah, this is at the lower, at the apex of the pectoralis, the lesion. That is why infiltrating into the apex of the pectoralis as well as the chest wall. If you have seen here, even there is some tethering, an area of enhancement at the apex more than the rest, and just focal thickening. These are the features signify the involvement of underlying structures. Okay. So if you have seen big animals, look far away. Even if the breast is dense or fatty, for other lesions representing multicentric or ductal extension or invasions of the adjacent structures. The invasion not always directly. It can be through a ductal extension as is seen in this case. Okay, so what is the interval cancer? Do you know the interval cancer? This case is an interval cancer. The interval cancer is a cancer detected clinically between mammography screening. Then the patient, she had mammogram screening and reported as negative. And before the second round or the second year mammography, to be diagnosed having a breast cancer. This is an interval cancer. So it is a missed cancer. And the causes for missing, as we described before, the lesion might occur even in retrospect. We might say retrospectively still the lesion could not be appreciated for the reasons or the factors we described before. Or the lesion might be frankly overlooked, as in this case, it's frankly overlooked, or noted but considered as benign, also might be in this case. Yeah, it was not overlooked, actually detected, but considered as benign. Subtle, non-specific, or non-actionable findings. Actually, this is non-actionable. Focal or area of asymmetry, not highly dense, seen in a single view, considered to be non-actionable findings. Okay? Like vague asymmetry, one view asymmetry, or if there is distracting lesions, which is a common false, like as we have seen before in our examples, when an obvious benign lesion and subtle suspicious findings sitting next to it. Okay, that is the interval cancer. What is the abnormality in this? This is not my case. All the previous cases are our cases. Either the majority are my cases and few are from our institutions, from the system. But this case is from the literature, because I could not find example for this pitfalls. That is why I brought for you from the literature. Okay.
I think abnormality on the right breast, I think.
Why you said the right breast?
Because there is as global asymmetry with architectural distortion.
Excellent, well done.
And thickening trabeculae or trabeculation.
Excellent, Hannah, excellent. Yes.
In intraductal invasion or thick band-like structure.
Trabecular thickening, trabecular thickening, global asymmetry, and trabecular thickening. What else? If you compare the two sides.
There is a band thick structure. I can see it in
the size of the breast. What about the breast size?
There is the smaller, would be a shrinken.
Excellent, well done. This is a shrunken breast, shrinkage breast. Okay, so this is one of the pitfalls, not always being picked up, because usually we consider, especially if the contralateral breast is relatively dense, yes, you might think that the larger breast is a site of abnormality, not the smaller breast. But we have to consider that sometimes infiltrative malignancy and result in shrinkage breast or shrunken breast. Okay, and here is obviously shown the arrow pointing to the pathological axillary lymph node. And this case, okay, this is the ultrasound, demonstrate large infiltrating mass in case of usually seen with which type of cancer?
Sclerotic cancer, sclerotic type cancer.
Lobular carcinoma.
Yes, it is commonly seen with lobular carcinoma, though the common presentation of lobular is a focal disease, not the diffuse shrunken breast. But when you have seen the shrunken, diffuse infiltrative breast with shrunken breast, think about lobular carcinoma as a common cause. But the lobular itself not commonly presenting in that way. So this is shrinkage breast due to lobular carcinoma. And the teaching point is, because the mammographic findings in these cases are subtle, often without discrete mass, comparison with the previous study will aid the radiologist in recognizing cases of diffusely infiltrating process. Here, you describe the findings, but you did not compare it with the earlier one. We forget to say this is the earlier mammogram and this is the recent one. You see, when we go and then we could appreciate the changes between the two, and definitely the site of interest is the right one. So it is important to look for the prior mammography, okay? And focus also, they said we have to focus on the posterior breast because the breast is shrinkage. So the parenchyma will shrink and we will leave more fat at the posterior part of the breast compared to the non-involved contralateral side. So you can look for these subtle findings. And you know that invasive lobular cancer is difficult to be diagnosed. Gross pattern is a single fire. Okay, often referred to as Indian filling. That is why it is not presenting as a mass, presenting as parenchymal changes, parenchymal architectural distortions, and it might infiltrate the whole breast and result in volume loss and shrinkage breast. Okay, this is another example of shrinkage breast, but in a case of inflammatory carcinoma. Okay, also involve the right side. And usually in shrinkage breast, when it is difficult, MRI is helpful. This example is also from the literature because they suspect this small circumscribed nodule to be intramammary lymph node. And even on ultrasound, if you look, you might think about a fatty hilum, but actually it is an irregular heterogeneous mass. Look for the surrounding rim or thick rim of halo, and biopsy performed, and they found it as small invasive ductal carcinoma. This is our case in the system. From the system I brought for you, reported the patients having multiple small nodules reported as intramammary lymph node, and there is one faintly seen here on the MLO, okay? And on tomosynthesis, the lesions, this one, proven to be typical intramammary lymph node, demonstrate the fatty hilum, as seen here. While that one was not well appreciated, is very much appreciable on tomosynthesis as a small speculated mass. Can you see it here? I make a zoom for that. It's not, and be cautious for just label all of these nodules without being very typical. And we are sure that are intramammary lymph node to make it intramammary, and now the use of tomosynthesis borders and the fatty hilum of this intramammary lymph node. What about this? This is an example you can see. And previously, when we have seen a fat, we usually labeled the lesion as bilateral. And we can consider in type of speculations as fat necrosis and these type of lesions. But recently, in the literature, they describe, due to the use of thin cut, in this case, it was biopsy proven to be lobular carcinoma. And due to the use of the thin cuts, okay, tomosynthesis, they found that the cancer can entrap distant fat, and presence of fat in lesions having a suspicious morphology should not preclude or should not defer the biopsy. We have to go for biopsy. We have to biopsy that types of lesions. Okay, so the presence of fat, it should not deter the biopsy. If the lesion is suspicious, in spite of presence of fat, we should not rush for just to report it as BIRAT 2 as before. For the encapsulated fat, usually encapsulated fat seen with a. Now we went through all the 4 patients factor as reader or observer to overcome this and to pass it and to avoid without falling down. We have to adhere to ensure that breast is adequately imaged, and we have to work up small developing asymmetries. We have to biopsy all new or enlarged solid masses if solitary. We have to get extra views and or ultrasound of finding which is suspicious on only one standard view. We should not, or we don't ignore subtle architectural distortion, especially if changing. Consider lobular carcinoma, invasive lobular carcinoma. If you find an indexed lesion, look for further suspicious findings, multiple and contralateral use of adjunctive imaging tools such as ultrasound and breast MRI to further evaluate indeterminate findings seen on conventional imaging. Okay, so هذه تحليل. I thought I brought this just for you, okay, as a special case to know something new. And I put it at the end for discussion. Who would like to take? Alas, we are at the end. This is the last case. Quickly, so as to Heidi, you are not with us today. Any volunteer, or shall I proceed?
I will take it. Okay, this CCView. First of all, the image quality of the MLO view is not so adequate. However, it showed.
Abir is talking?
Yes.
Okay, Okay.
Hello?
Yes. Proceed.
Yes, the image quality is not adequate for the MLO. However, it showed a mass in the right breast posteriorly, in the posterior part of the breast centrally. The mass is hyperdense with circumscribed partial obscured margins.
Circumscribed or obscured?
Circumscribed, partially obscured.
How come, Abir? Abir, this is speculated mass. This hyperdense
Yes,
speculated
it's
masses.
diffuse.
You see, you have multiple hyperdense speculated masses. How, يعني, just tell me, is it multifocal disease? Is it multicentric disease? Is it unifocal disease?
It could be a mass with acetylites.
Okay, so
multifocal.
Multifocal is okay. Okay, what about this area? How you are going to interpret this area? This is far away. So, and why?
Yeah.
What about the ACR for the breast?
It's A to B.
Okay. Both sides?
Mostly fatty. It's mostly fatty breast.
Huh? What is the difference between the two?
For the left breast, it's A. For the right breast, I think it's A, but because of these masses, it gives us some areas of higher density.
Okay, so there is lesion edema and there is band-like strands, you see, extending
towards the nipple.
between masses and going toward the nipples. Okay, so you might have you have questions to be multicentric disease. Definitely you have multifocal with questions toward multicentric disease and questions for Bacterales involvement. Okay.
Yes. Yes.
And what about
there is no clear
what
fat
about
between the pectoralis and
the contralateral breast? Is it a normal breast?
No, it showed also an area of focal asymmetry, also more posteriorly. Same location of the other breast mass, other side of the breast.
There is calcification high up. And if I told you this patient had history of left breast cancer 17 years before.
Left breast cancer. So it could be a local recurrence of the breast cancer with mets to the contralateral breast.
Where is the recurrence?
The area of the focal asymmetry in the left breast.
What about this focal asymmetry? How you can describe it? Okay, let me show you. Let us proceed. Okay, because of the time. Okay, this is the ultrasound. Okay, demonstrate. If you look like that. This is axillary lymph nodes. Okay, malignant, and this is the largest, the index lesions. These are the index lesions. Where in the lower outer breast. But this cursor here in the lower inner breast. This is lower inner satellites. Okay, this is upper outer. This is upper outer. Upper outer. Okay, upper inner. So this is what we have seen, all representing, and even here you have duct tension for the nipple. Yeah. So this is a case of
multicentric.
Multicentric. It confirms that it is multicentric. And if you compare, this is the upper outer lesions. You see the ductal extension on CT, and can you see it here? The ductal extension
yes.
On ultrasound.
Yes, it's clear.
The same corresponding lesions. So you can make use even of the CT to local stage the lesion. If you remember that day, I said we can make use of the CT for local staging. Sometimes in a fatty breast, we don't need to proceed for MRI. It can add a lot. And if we look here, Have you seen? These are the
Definitely,
adjacent two big lesions at the posterior breast. And look for the ducts, and this one satellite lesions. Look for the ductal extension here, and look for the ductal extension between the two lesions are interconnecting. This is the ductal extensions, and these more anterior multiple satellite nodules with, you see, this is abutting the nipple with nipple enhancement, suspicious for nipple involvement. And look here, even this satellite nodule very close to the nipple, okay? And these are multiple lesions here. So the questions here about, is the pectoralis involved or not? And what about the contralateral breast? You said the contralateral breast, there is recurrence. Could you see appreciate the recurrence here? This is calcification.
There is area in the first row.
This is the
In the
area.
first row of the
Yeah,
CT,
this is the area.
the middle image.
Yeah, that is the area. What about this area?
The first
does it
row
look like the cancer in the contralateral breast?
No, it's not like it, and it is even non-enhancing.
Yes, and it is fatty.
Yes.
Fat, yeah. So can you see any nipple here or something? Okay. This also we can use the multiplanar of the CT for local staging. Here, can you see the nipple enhancement and how the adjacent nodule is extending? This is a duct enhancing duct. That is the same duct from this satellite nodule extending into the nipple with enhancement, which make it more suspicious for nipple involvement. And these multiple satellite nodule interconnecting. You see, these lesions interconnecting, giving you the added density, okay? And this is the nipple in the contralateral breast, but the whole area is fatty. I could not appreciate. And again here, these are the lesions interconnecting. Look how the band-like density seen on mammography. Look, this the tumor band extending between all, even upper outer lesion. Look for the tumor band extending from that and from this. I don't know. There is interconnections between all of the lesions, as if even multifocal, as if it is the same ductal system, even for the lesions far away in the upper superior breast. And here, if you look for the peripectoral edema, and if you come here, look for the lesions, is almost okay abutting the pectoralis. And look here, the edema is enhancing, and the pectoralis itself is focally thickened and enhancing. And look for this extension into this extension within the pectoralis signify, look for the extension into the pectoralis signify the pectoralis itself is being involved. Okay, the pectoralis is involved. But look for the contralateral, look for that area you have seen. It looks like a band-like, and there is fat within. Look at it here. Have you seen it? What does it mean? Again, the multiplanar, you can see here the malignant axillary lymph node, and look for the band, tumor band. See, you have seen on mammography between all of the lesions and the nipple involvement. And here also you can see the pectoralis, the invasion into the adjacent pectoralis. And if you go even here from the left side, this is the intercostal on the left side. When you come to the right side, look for this focal thickening and enhancement, signify that there is what? There is chest wall involvement. Not only the pectoralis is involved, but also there is adjacent chest wall involvement. But okay, we finish that. Look for here the breast is fatty. Look for this area. This is what This which muscle? This which muscle?
Which one?
Abdominal rectus.
Rectus abdominis.
Rectus
This is the right
abdominis
rectus.
muscle.
Where is the
Yeah.
left one? Where is the left rectus abdominis? It's missing.
It is a
Can you
physical
see?
view.
Can you see it reflected? Can you see it here? Reflected, but it is atrophic. Reflected because it's not working. Reflected here. You see, this is the muscle. Is reflected. Yani the CT helping us even to show the muscle flap. The muscle is reflected from the abdomen into the left breast, causing making the reconstruction of the breast. This is the muscle here. That is why it's atrophic, contain fat. This is a flap. What you have seen on mammography is a muscle flap, and the CT helping us to show us that it is the muscle flap is not latissimus dorsi, but the muscle flap is rectus abdominis muscles. Have you seen it here on the axial view and here on the sagittal view? Okay, and here, okay, on the coronal view, demonstrate, and this is the area of dystrophic calcifications. Okay, so in conclusion, many of the factors for breast cancer missings are not related to actual negligence of interpreting physicians. However, knowledge of imaging pitfalls, their appearance, etiologies, and methods of artifacts, okay, reductions is extremely helpful for accurate interpretations and accurate diagnoses and eliminations of false positive and false negative diagnosis of breast cancer. The radiologist can, or the radiologist should take the following steps when interpreting mammography to decrease the false negative. They have to be strict about positioning and technical requirement to optimize image quality, reviewing clinical data, correlations of imaging with available patient clinical history. Do not rely on screening views alone to diagnose and detect abnormality. We have to complete the evaluation with diagnostic mammography, and mammography still remains the primary imaging modality for breast cancer detection. However, we have to emphasize the use of adjunctive imaging tools such as ultrasound, breast MRI, or even nuclear imaging to further evaluate indeterminate findings seen on conventional mammographic imaging. Ultrasound help assess a palpable or mammographically detected masses. Okay, we have to be alert to subtle features of breast cancer, and we have to compare current images with multiple priors. Sometimes cancer might be missed in one of the prior imaging, and sometimes also the size of the lesion might appear to be stable, but when it will compare with multiple prior, you might appreciate the change in size. And we have to look for other lesions when we find mammographic abnormality and judge the lesion by its most malignant features. Integrating of double reading and or CAT for mammographic examination is helpful. Thank you for attention.